Hello everyone. So I'll be taking up trauma from oral surgery, which is a very important topic, and it includes mandibular fractures, middle third fractures, and orbital blowout fracture. So these are very vast topics. So coming on to the mandibular fractures, we'll cover mandibular fractures first, and in this we'll be studying about various classifications of mandibular fracture, then in detail about condylar fracture. In that, we'll be studying about etiology, classification of condylar fractures, clinical features, in detail management of condylar fractures, what is the treatment protocol for condylar fractures depending upon various age groups, the complications of treatment, and then signs and symptoms of midline fractures, and then general principles in the management of fractures. So a mandibular fracture is asked as a long note. General principles itself can be asked as a long note. Condylar fractures is asked as a long note, and along with the very long classification of mandibular fractures, I'll try to make it easier for you to remember. Now, beginning with the classifications of mandibular fracture, we'll be studying about Krugers, general classification, anatomic classification, classification of the fracture according to its favorability. What it means, I'll be explaining it to you. AO classification and kazanjian and converse classification. So these are the main five classifications. Along with these, there are a few small classifications. Now, coming on to the first classification, which is Krugers general classification. It includes simple or closed fracture, compound or open fracture, comminuted fracture, complicated or complex fracture, impacted or telescopic fracture, green stick fracture, or pathological fracture. So, simple, compound, comminuted, complicated or complex, impacted or telescopic, green stick fracture, or pathological fracture. These are the 1, 2, 3, 4, 5, 6, and 7 categories which are included under Krugers general classification. So, what is a simple or closed fracture? As the name says, closed matlab it will not communicate with the external environment. So, if there is a fracture in mandible, for example, in condyle, coronoid, or ramus region, the fracture line will not communicate with the external environment. Externally क्या present है? Mucosa or skin, because it will not communicate with the external environment because the overlying integument will be intact. So it is known as simple or closed. Closed, why? Because it does not communicate with the external environment. Then comes the compound or in compound or open fracture, the fracture line communicates with the external environment because it is open, so it will communicate with the external environment via skin or mucosa. We know intraorally there will be mucosa, and externally it can communicate with the face via skin. So, compound or open fracture is the one which communicates with the external environment via skin or mucosa. So, in simple or closed fracture, the fracture line does not communicate with the external environment, while as in compound or open fracture, the fracture line communicates with the external environment. Then comes the comminuted fracture. Comminuted fracture, it occurs because of high velocity impact and in which the bone is crushed into multiple pieces. See, the bone is crushed into multiple pieces. Then comes the complicated or complex fracture. It is complicated because it is associated with injury to some vital structures, for example, nerves, inferior alveolar nerve or facial nerve, or then vessels, for example, inferior alveolar vessels. Then, complicated fracture is associated with the nerve or vessel injury. Then comes the impacted or telescopic fracture. This is a fracture which occurs commonly in maxilla and less commonly in mandible. In this fracture, one fragment of the bone will be firmly driven on the other, which makes the movement impossible. See, if one fragment is broken, it will be firmly driven over the other fragment such that there is no appreciable movement between the two. Then comes the green stick fracture. It is also called as incomplete fracture, and it occurs commonly in children. Why is it incomplete? Because we know there are two cortical plates, buccal and the lingual. In this, one cortical plate will be broken but other one will be bent. So this occurs because bone is elastic in children. So green stick fracture is common in children because of the elasticity of the bone in children. Then comes the pathological fracture. It is the fracture which occurs due to mild injury in a bone which is diseased or pathological. The disease in the bone makes it weak, so it fractures even due to mild injury. The disease of the bone can be general skeletal disorders or localized skeletal disorders. General में आएगा endocrine disorders और osteoporosis, osteomalacia, etc. And localized skeletal disease में क्या आएगा? Cysts, tumors, osteomyelitis, osteoradionecrosis, etc. A quick revision of Krugers general classification: simple or close fracture, the fracture which does not communicate with exterior. Then compounded open, therefore it communicates with external environment via skin or mucosa. Then comminuted fracture, the fracture in which there are multiple pieces of in which the bone is crushed into multiple pieces. It occurs because of high velocity impact, as in gunshot wounds. Then complicated fracture, the fracture which is associated with some injury to some vital structure, for example nerve or vessel. Then impacted fracture, which is common in maxilla, and the movement will be inappreciable movement, as the name suggests, impacted, therefore there will be no movement. Then green stick fracture, the fracture which occurs commonly in children due to elasticity of bone, and one cortex will be broken, other will be bent, therefore it is incomplete fracture. Then pathological fracture, it is a fracture which occurs due to even due to mild injury in a bone which is in a pathological state or diseased or weak because of some disease. Then and the diseases of bone can be general or localized. So in anatomic classification, Dingman and Natvik's classification, remember the names and the percentage of the frequency of the fractures in each of the segments. The most frequently involving site is the condyle. It is the weakest part. Then Rowe and Kiley's classification, it is the alveolar fracture involving basal bone or alveolar fracture not involving basal bone. If this is the alveolus, if it involves basal bone, it will be the alveolar fracture involving basal bone, and if it does not involve basal bone, it will be the alveolar fracture not involving the basal bone. So anatomic classification, it is the simplest: Dingman and Natvik classification and Rowe and Kiley's classification. Then comes the classification of fracture according to the direction of fracture line and favorability for treatment. This is commonly applied for angle fracture. So in this, the fracture can be horizontally favorable, horizontally unfavorable, vertically favorable, and vertically unfavorable. Let's understand this diagram first. This is the mandible, and this is the masseter, which is present on the lateral surface of the mandible, and this drawn in red is the fracture line. So in horizontally favorable fracture, the fracture line the fracture line passes from alveolar margin. This is the alveolar margin. The fracture line passes downward and forward. Downward, it is coming downward and then it is going forward. So when the fracture line passes from alveolar margin downward and forward, then upward displacement of the posterior fragment is prevented. This is the posterior fragment. इसका upward displacement is prevented. Upward displacement क्यों हो रहा है? Because of the presence of masseter. Masseter is an elevator muscle. It tends to pull the mandible up in the upward direction. But because of this direction of the fracture line, see, even if the masseter wants to pull it, it is not able to pull it upwards because of the obstruction created by the body of the mandible. So it is horizontally favorable. Okay, the fracture line passes from alveolar margin downwards and forwards. Then upward displacement क्यों होगा? Because of masseter is an elevator muscle. Upward displacement of the posterior segment is prevented. Okay, because of the obstruction caused by body of mandible. Such a fracture is termed as horizontally favorable. Then comes the horizontally. You don't need to write all of it, just for the sake, even if you draw this diagram and understand what actually favorable means, it will be enough for you. Okay, horizontally favorable क्या है? इसमें direction of fracture line is downward and forward, and the upward displacement of the posterior fragment is prevented. Then comes the horizontally unfavorable fracture. इसमें see this one, red one is the direction of the fracture line. इसमें the fracture line is passing from the alveolar margin, एक तो downward तो है ही, and then backward. So in this, the upward displacement of the posterior fragment is uninterrupted. Okay, so this is considered as horizontally unfavorable. However, sometimes upward displacement of the fragment can be prevented because of the presence of teeth in the posterior segment, which comes in the contact with the maxillary teeth. So kabhi kabhi kya hoga, even if the direction of the fracture line is like this, downwards and posterior backwards, the upward fragment can be prevented if teeth are in occlusion. Then comes now coming on to the vertically favorable and vertically unfavorable fracture. In horizontally favorable and unfavorable fracture, there was the role of masseter. In vertically favorable and unfavorable fractures, there is the role of medial pterygoid and mylohyoid muscles, which tend to move the mandible medially, while masseter pulls the mandible in upward direction. That is, it is an elevator muscle, while medial pterygoid and mylohyoid tend to move the mandible medially. So what is a vertically favorable fracture? See, when the fracture line passes from outer or buccal plate, this is the outer or buccal plate. When the fracture line passes from outer or buccal plate obliquely backward, it is passing from the buccal plate backwards, and lingually it is passing from the buccal plate ek to backwards, and then this is the lingual side. Lingually, medial displacement of the posterior segment. Medial displacement of the posterior segment. This is the posterior segment, and this muscle pull is showing the medial displacement. Medial displacement of the posterior segment due to spasm of medial pterygoid and mylohyoid muscle will be resisted by the fracture line. See, the direction of the line is such that the medial displacement of the posterior segment is prevented by the spasm of the mylohyoid and medial pterygoid muscle. In horizontally favorable and unfavorable fractures, there was the upward displacement of the posterior segment due to masseter. In vertically favorable and unfavorable, there is the medial displacement of the posterior segment due to medial pterygoid and mylohyoid muscle. In favorable fracture, this displacement is prevented. Same in horizontally. The horizontally favorable fracture, the upward displacement was prevented. And the same will be in vertically favorable fracture. The medial displacement of the posterior fragment is prevented because of this direction of the fracture line. So such a fracture in which the fracture line passes from the outer plate obliquely backwards and lingually, and the medial displacement of the posterior fragment is prevented, is termed as vertically favorable fracture, and vice versa for the vertically unfavorable fracture. That is, when the fracture line passes from lingual, here the fracture line was passing from buccal plate, here the fracture line is passing from lingual or inner plate obliquely backward and obliquely backwards and buccally. Okay, in this the fracture line was passing from the buccal plate. Here the fracture line is passing from the lingual plate obliquely backwards buccally. The movement of the posterior segment will take place as a result of medial pterygoid muscle pull. इसमें क्या होगा? The posterior segment will move medially. Therefore, it is vertically unfavorable. So, what determines the favorability of the fracture? Favorability for treatment. If the fracture segment has moved or not due to muscle pull. If the fracture segment has not been moved by the muscle pull, it will be horizontally favorable or vertically favorable. If the fracture fragment has been moved due to the muscle pull, it will be horizontally unfavorable or vertically unfavorable. In horizontally unfavorable fracture, the posterior segment is pulled upward, and in vertically unfavorable fracture, the posterior segment is drawn inwards or medially due to the muscle pull. The diagrams in this classification, actually no, the classifications are important, and how to remember the diagram of the direction of the fracture line, even if you forget that it passes from the alveolar margin downward and forward. Just remember, in horizontally favorable fracture, this is the fracture line. It will be parallel to this ramus. Okay, we know the mandible flares outwards in an obtuse angle like this. Okay. So, in horizontally favorable fracture, this fracture line will be parallel to this flaring, okay? While as in horizontally unfavorable fracture, this, if this is the mandible, this is the outward this is the ramus flaring outwards, the fracture line will be like this. इसमें क्या था? It was parallel to the surface, while as in this the fracture line is like this. So you can easily write on your in your own words like the fracture line is passing from the alveolar margin downwards but backwards. So this is horizontally favorable, इसमें parallel होगा ऐसे, horizontally unfavorable में ऐसे जाएगा, parallel नहीं जाएगा, and vertically favorable में क्या होगा? जो हमने सेकेंड में ड्रॉ किया वो थर्ड में भी ऐसे हम ड्रॉ करेंगे, एंड देन इन वर्टिकली अनफेवरेबल जो हमने फर्स्ट में ड्रॉ किया था डायरेक्शन वैसा हम इसमें ड्रॉ करेंगे. इसका और इसका डायरेक्शन लाइक फॉर द डायग्राम पॉइंट ऑफ व्यू सेम रहेगा फ्रैक्चर लाइन का, and then we can easily write about the direction of the fracture lines for the for this classification. Then comes the Kazanjian and converse classification. Kazanjian and converse classification, it is according to the presence or absence of teeth in respect to the fracture line. We know that the dentition can be used as a guide for reduction procedure and can be also used for fixation or immobilization. So what is reduction? Reduction is the treatment procedure in which it is the first step in which we draw the fracture fragments to their original anatomic location. So this classification classifies the fracture according to the presence or absence of teeth in respect to the fracture line. Because the presence or absence of teeth, that is the dentition, it can be used as a guide for reduction and fixation procedures. We will be studying about it in detail in the coming videos. So in edentulous patients, occlusal guidance is lost. Similarly, in deciduous dentition or mixed dentition, special splints need to be constructed as a fixation or immobilization device. This is the significance of this classification. So how does this Kazanjian and converse classification classifies the fracture? In this class, it classifies the fracture into class 1, class 2 and class 3 fractures. In class 1 fracture, teeth are present on both sides of the fracture line. See, if this is the fracture line, teeth are present on its both sides. In class 2, teeth are present only on one side. And in class 3, teeth are absent on both sides of the fracture line. So, Kazanjian and converse classification according to the presence or absence of teeth in relation to the fracture line. If teeth are present on both sides, it will be class 1. If teeth are present only in one side, it will be class 2. And if teeth are present, if teeth are absent from both the sides, it will be class 3. It is further classified into the subtypes, but we don't need to go into the details because anyways we don't get time to write all of it in the exam, so keeping it concise.